Hello and welcome everyone. My name is Matt Shepard. I'll be moderating today's webinar highlighting Medicare home health coverage, occupational therapy, and practical tips to obtain care. We are presenting this today in partnership with the American Occupational Therapy Association. Our Center for Medicare Advocacy presenters today are Executive Director Judy Stein and Associate Director Kathy Holt. And we're very excited to be joined today by Sharmila Sandhu, Vice President of Regulatory Affairs for the American Occupational Therapy Association, and Ciera Whitmore, an occupational therapist from Stillwater Medical Home Health, to really dig into OT with us today. Sharmila will tell us all about AOTA in a few moments, but for those who don't know, the Center for Medicare Advocacy is a national nonprofit law organization that works to advance access to comprehensive Medicare coverage, health equity, and quality health care for older people and people with disabilities by providing exceptional legal analysis, education, and advocacy. Now a bit of housekeeping about the system that we're going to be using today and some details for today. The session should be familiar to pretty much everybody by now, although unlike in a typical meeting, only our speakers are going to have video capability today. And I will be keeping what I expect to be a pretty large audience muted during the presentation portion. On the topic of audio and muting, hopefully everybody can hear me, which means you've used the information in the email you received after registering to successfully log in. Yay. And you have either dialed in by phone, old school, or you've got good quality working speakers on your computer, either of which is great. Audio and video, of course, are always at the whim of the internet. So if your audio is an issue, we do have that old school phone dial-in option still using this system. So you can always look in the control panel under audio or look on your confirmation email, find the number and dial in should the internet suddenly fail you. Now, more about that control panel I just mentioned. As I'm sure some of you are familiar with by now, we have a couple key features. If you look at the buttons on the left side of that panel, there's a little orange arrow that'll let you hide the panel so it's not in your way. There's a little square that'll let you watch things in full screen mode. And then there's a little picture of a hand. That's going to be used to indicate that you have a question or a comment. While our presenters provide their information, as I noted, we're going to keep attendees muted. When we open it up for questions, comments, and discussion, that little hand icon can be used to indicate that you'd like to speak, and I can unmute you. At which point we usually have a little dance of me unmuting while you try to unmute, and then eventually we get there and you're unmuted. However, if for some reason that doesn't work out and we can't hear you, there's a questions section of the control panel. You can expand that, type questions right into it at any time, and I'll do my best to translate those and pass them on to the presenters. As I've mentioned a couple times, we're expecting a pretty large audience today, so please do hold any individual case-specific type questions. We're trying to address a broad range of issues today in the time that we have. And in addition, we did solicit feedback on our registration form, and I know that our presenters have tailored their content today to try to address some of the common threads that we saw in those. Thank you all once again for your attendance, and I'll now pull up Sharmila Sandhu of the American Occupational Therapy Association. Sharmila. Welcome.
Yes. Hi there. Good afternoon, everyone, and thank you for that introduction. My name is Sharmila Sandhu. I'm the Vice President of Regulatory Affairs, and we'll welcome the audience today. Very proud to co-host this webinar with the Centers for Medicare Advocacy. And just a very quick overview of the American Occupational Therapy Association. AOTA, it currently sits around 56,000 members, and our membership is made up of occupational therapy practitioners that involves occupational therapists, occupational therapy assistants, as well as students of occupational therapy. Our mission statement guides us to advance the work of occupational therapy practitioners, focused on advocacy within the policy realm, practice realm, and continuing development in professional education. We continue to work to advance the profession as we move into a variety of different industries and areas. So with that, I believe I will turn it back over to Judy Stein to begin.
Thank you, Sharmila. It really is a pleasure, indeed an honor to partner with you all today. Occupational therapy is too often misunderstood and always so important. So we're going to address today occupational therapy, particularly in the context of Medicare coverage for home health care. And here is how we'll go about that. We will review the Medicare coverage criteria for home health care, skilled services, aids, and medical social services. Then we'll move on to examining the role in particular of occupational therapy in an individual's home health plan of care, explore a case study regarding occupational therapy services and Medicare coverage, and consider current access to and provide tips to obtain Medicare coverage home health care services, which, as I'm afraid too many of you may know, is not always easy. Then we hope to have time for questions and discussion. Next slide, please. So in general, let me just set out the basic criteria for Medicare coverage of home care as set out by the federal law and regulations and Medicare policy. Just to be clear, I'm not an occupational therapist, I'm a lawyer, and my focus as a lawyer has been on Medicare coverage for decades. Under the law, in order to get Medicare coverage for home care, the patient must be under the care of a physician or an allowed practitioner. So it could be an advanced practice registered nurse or a physician's assistant, as well as a physician who orders and is providing care to the individual. That healthcare practitioner must certify and along the course of treatment, recertify the patient's eligibility and order home health care services. He or she must, or they, establish and review the plan of care, do that at least every 60 days. The authorized healthcare practitioner must also certify that the individual is what's known under the law as confined to home. We often refer to that as homebound, and I'll give some details about that, but let it be said that that does not mean that the person cannot leave home or is bedbound. And finally, the individual must need and receive skilled services, which means nursing or therapy, in order to receive any home health care services. It's important to note that the Medicare payment depends upon specific initial certification and recertification requirements, and that those recertification requirements are met. For an example, that the skilled practitioner has seen the patient face to face and has certified that the individual is homebound. On to the next slide to discuss further about coverage. Medicare coverage, when available, as I said, the individual must need and receive at least one skilled service, and that would include skilled nursing, physical therapy, or speech-language pathology services. As Sharmila and Ciera will tell us, unfortunately, occupational therapy will not what we call trigger the whole array of home health care to begin, but occupational therapists can set out and start the service, but it won't be enough to continue care and get it in place. If the individual is receiving skilled services, nursing, physical therapy, speech language pathology, then the individual can receive what's known as dependent services. That is, they depend on the receipt first of skilled services. Most importantly, for quality of life for patients living at home, are home health aid services. These are individuals who provide personal hands-on care. We'll discuss what that means in a moment, but generally it means bathing, dressing, feeding, providing care that the individual cannot do on his or her own without assistance, and help with the daily activities of living. Medical social services are also covered if skilled services are being covered, and some medical supplies can also be covered under the Next slide, please. Important to note Medicare home health coverage is not time limited. So often people are told that you can only get home health care, if at all, for 30 days or 60 days, or perhaps even shorter period of time. But the Medicare Benefit Policy Manual itself, that policy manual written by those who run the Medicare program, specifically says that Medicare home health coverage continues to be available so long as skilled care is needed and the other threshold criteria are met. So if a person continues to need that nursing, physical therapy, or speech language pathology, or those have gone but occupational therapy continues, then Medicare coverage is able to continue as well under the law for long as it is legally necessary and the individual remains confined to home. Payment, indeed, can be made for an unlimited number of covered visits, and there's no limit on the continuous number of recertifications that the patient's practitioner can provide, as long as the individual needs these services and meets the threshold criteria, being homebound and needing a skilled service and having a plan of care. The care can continue and the allowed practitioner can continue to certify the care. And you see below a citation for that to the Code of Federal Regulations and the policy manual. Next slide, please. Confined to home is often, as I said, referred to as homebound, and it includes two basic prongs. Number one, the patient must either, because of illness or injury, need the aid or support of a device like a cane, walker, or wheelchair, the use of special transportation, or the assistance of another person in order to leave their residence. Or the person must have a condition such that leaving home is medically contraindicated. That is, they're physically able to ambulate on their own, but it's not indicated as a good idea for them to do so, either to cognitive decline or perhaps to a propensity for falling. The second prong is that there must be what's called a normal inability to leave home. That is, that this individual generally cannot leave home regularly, and leaving home must require a considerable and taxing effort. The notion is that if the person can consistently get outside the home regularly in order to get medical care, then the program doesn't want to provide home health care, the care at home. But if the person meets these criteria, then the program, Medicare, will pay or should cover for care to come to the patient at his or her home. And you see the policy manual where this is cited from. Now, it's often told that people are not homebound when they, in fact, still meet the homebound criteria. For instance, absences to receive health care. If a person must go to get care that cannot be provided at home, then the individual is not disqualified from being considered homebound, which, as you realize now, they have to qualify as homebound in order to get Medicare coverage for home care. So if it is explicitly stated that a care that's provided in adult day care for psychosocial purposes, therapeutic or medical treatment will not disqualify an individual from being considered homebound, nor will going to medical appointments. Absences taken on an infrequent or relatively short basis are also not considered ways to be disqualified from homebound. An individual can go to religious services, indeed weekly religious services, a family reunion, funeral, graduation, or other infrequent or unique events. An occasional walks around the block or to get a haircut should not disqualify a person from being homebound. The same is true, though this often becomes a problem, having more than one home, then an individual can travel between them and still be considered homebound in each of those residences. And there again is the policy manual citation for this. Next slide, please. Standards for skilled services. This is important because, as I indicated in the beginning, There is no coverage possible if the individual is not receiving a skilled service. Skilled nursing, SN, PT, physical therapy, speech language pathology, SLP, or occupational therapy. Skilled means that it's inherently complex, so inherently complex, the service, that it can be performed safely or effectively only by or under the general supervision of a qualified professional. And note that supervision component. Often I like to say to the family or doctor or patient, if they're saying, well, the person doesn't qualify because they don't get skilled care, is it true that that care could be provided safely and effectively without any intervention or supervision by a therapist or a nurse? If the answer to that is no, Medicare coverage may well be available. Medically reasonable and necessary is also a basic criteria. Based on the individual's condition, overall condition, an individualized assessment must be made of what the patient needs to treat the illness or injury, or to maintain the current condition or prevent or slow further deterioration of the individual's condition or function. Restoration or improvement is not required. You can get Medicare coverage if the skilled services are required to maintain the individual's function or slow deterioration. And that is extremely important and often honored in the breach. That is, people are told they're stable or they have reached their level of improvement, and then since they can't improve anymore, they can't get a skilled service and must be cut off home care. If that happens, please do contact the Center for Medicare Advocacy. Next slide, please. Skilled nursing and therapy services, again, this is a key component. The federal regulations stated here as CFR, Code of Federal Regulations, specifically states that restoration potential is not to be the deciding factor, and that even if full recovery is not possible, a patient may need skilled services to prevent further deterioration and preserve current capabilities. Thanks to you, we got a number of questions during registration prior to this webinar, and a number of them had to do with whether services could be provided to someone who's fully is a quadriplegic and fully dependent for all their services, can only move eyes, for example. And the fact is that the answer is yes, such an individual may need occupational physical therapy to prevent or limit pain, to keep rigidity more relaxed, and there could be very valid reasons for skilled services and certain skilled nursing to be provided for such a patient. Improvement is not required, and the patient's overall medical condition should be considered before making a Medicare coverage determination. If the illness or injury is acute, chronic, terminal, or expected to last a long time, care should still be considered as necessary if the patient meets the qualifying criteria, one of which is, could that skilled care be effective without the assistance of a professional or the supervision of a professional? Again, if the answer is no, push ahead and try to get Medicare coverage. Skilled care has been clearly defined as possible for patients with stable conditions, and you can find that at this section of the Medicare Policy Manual. Next slide, please. Skilled nursing must be intermittent or part-time. That is less than daily visits, but at least once every 60 days. If less frequently or on a predictable period of time, that is, let me repeat that, daily, but at least once every 60 days, or daily, but only for up to 21 days, except that if after 21 days, the care provider, the healthcare provider thinks that the need for daily services will end at another finite period, then those daily services can continue. So once again, it's less than daily, but once every 60 days, or daily, but up to 21 days. And after 21 days, the healthcare provider can extend that daily period of time if he or she still thinks there's an end in sight. There is an exception to this, and that is for a person who cannot self-inject and needs daily insulin injections provided by a skilled nurse. Next slide, please. Examples of skilled nursing I'll go over briefly since we're focusing on therapy, include observation and assessment of the patient's changing condition, patient education services, which also may include educating the family member, overall management and evaluation of a care plan. Specific skilled services are IV, intravenous or intramuscular injections, intravenous or enteral feeding, suprapubic catheter replacement, treating extensive decubitus ulcers. These are examples of very definitive per se skilled services. But note that observation and assessment, also management of a care plan, and patient education are also considered under the federal regulations to be skilled services. Next slide, please. Skilled therapy is covered when there is an expectation that the condition of the patient will improve materially in a reasonable and predictable period of time, or, and I can't say or definitively enough, or the individual's unique condition requires specialized skills, knowledge, and judgment of a qualified therapist to design or establish a care plan, or to perform that care plan so that it is safe and effective to maintain the individual's function or condition or slow decline. And that is extremely important and was ruled to be so by the court, federal court, in 2013 in a case known as Jimmo versus Sebelius. And here's the citation to a settlement agreement in which we entered into with the Medicare agency, the Federal Health and Human Services Department, and the Centers for Medicare and Medicaid Services. Next slide, please. So some summary key points. An individualized assessment. What does this patient need regarding eligibility for coverage is required by the law. Restoration improvement is not the only way to qualify. It's a way, but not the only way. Medicare should never be denied because the individual has a chronic condition or needs services to maintain his or her condition. Skilled therapy and other services can be covered. I know I'm repeating this, but it's so important. I need to drum it into people's ears who make Medicare decisions because they so often get it wrong. Medicare is available to maintain current capabilities or to prevent or slow further deterioration. And coverage can continue so long as the qualifying criteria of being homebound, having a care plan, and being served by a Medicare certified agency remain in place, and the patient continues to need these skilled services. Home health agencies must submit a claim, by the way, to Medicare if the beneficiary or someone officially helping him or her requests that be done. So the individual can get a claim into the system, even if the Medicare home health agency doesn't think it's valid. But the individual will be liable for the payment unless and until Medicare payment is approved. Next slide, please. If these skilled services are covered, then as I said, dependent services will also be coverable by Medicare. And those are sometimes such an important factor in allowing the person to stay at a home with a decent quality of life. So let's look at those. The most important of these is home health aides. How much can be covered under the law? Combined with skilled nursing, personal hands-on care, which is what defines home health aides, personal hands-on care, can be covered for up to 28 hours combined with nursing services, or subject to a case-by-case basis, they may be covered for up to 35 hours if the individual's condition specifically calls for that and the healthcare provider certifies it. So under the law, there's quite a bit of home health aid services that are theoretically covered. Next slide, please. Here's the Code of Regulation that defines what home health aides are and what they can do. Here are some of those definitions: bathing, dressing, grooming, caring for hair, nails, oral hygiene to facilitate treatment or prevent deterioration, changing bed littings, feeding, assistance with elimination, routine catheter and colostomy care, help with bed mobility and transfers and ambulation, medication assistance, and simple dressing changes that don't require a skilled nurse. Now, I'm giving you all these specifics and saying them fairly quickly, but the reason I'm telling you that giving you this list, and it's not entirely inclusive, is that unfortunately, very often when someone calls a home health agency for care, they're told that bathing and dressing are what maybe grooming are what the home health agency can provide. Under the law, all of these services and some others qualify as Medicare covered home health services. Next slide, please. Here's an important point. It's very often that we hear that the patient cannot get Medicare coverage because he or she does not have an able and willing caregiver at home. But the patient is entitled to have reasonable and necessary services covered by Medicare under the law without regard to whether someone else is available to furnish the services. Indeed, the Medicare policy manual states that there is a presumption. It's to be presumed that there's no able and willing person in the home to provide the services. Unless the patient or family indicated otherwise, the home health agency should not assume or require that there be another person in the home to provide the services. They shouldn't either deny home health services because they think someone at home should provide them, or deny home health services because there's no one at home and they think it's unsafe. Where someone is or has stated they will be providing services that adequately meet the patient's needs, it's not reasonable and necessary, however, for the home health agency to furnish the aids as well. But you can see there's a fine line there, and the patient's caregivers do not have to be in place. She or he does not have to have caregivers, and family and friends do not have to be willing or able to provide the services. Next slide, please. With that, I want to hope that you have a good background on what Medicare home health care and services can be as coverable under the law. And I want to move it over to our friends at the Association of Occupational Therapy. Sharmila, your turn.
Great. Thank you so much, Judith. So I'm going to start in just to kind of follow how Judith did a beautiful job talking about the coverage criteria for services under the home health agency benefit. Just wanted to start with what is occupational therapy. This is a slide we've worked on to really try and explain that the discipline of occupational therapy began with the concept of occupations, which are meaningful everyday activities that an individual needs to complete or wants to complete. And everybody has occupations. It's across the lifespan. So from a toddler whose occupations might be play or learning and developing important skills, to adults who have occupations involving self-care, grooming, dressing, engaging with family and friends, including work, and as well as managing their home. Additional occupations might include more complex activities like cooking a meal from beginning to end, or accessing public transportation in the community. So occupational therapy services are skilled, evidence-based interventions that help a client meet their goals as part of a plan of care in the therapeutic process under the healthcare system and under Medicare. Judith did a beautiful job of referring to many of the provisions in the Medicare Benefit Policy Manual, and I'm going to kind of re-highlight a few of those. Next slide, please. So, but before that, I do, just as a quick overview, some of what AOTA also does is we represent a powerful voice for the profession of occupational therapy. We are advocating on behalf of consumers at state legislatures and all the way to Capitol Hill, in addition to on behalf of the practitioners who provide occupational therapy services and students. We work every day to protect access to the profession. And there are a number of key issues, and only highlight a few of them here. Some of the things we're currently working on is expanding the occupational therapy licensure compact, fighting against a variety of Medicare limitations, primarily most recently in reimbursement, but also including those, of course, in home health. We work across the lifespan in almost every healthcare setting you can imagine. We also work in the field of education, K through 12, and we're supporting expansion of OT telehealth services and protecting the scope of practice. Next slide. So I did want to highlight some of the coverage criteria areas that Judith talked about of occupational therapy specifically, in an effort to ensure that consumers and advocates like yourself can ensure that you can receive occupational therapy when it's medically necessary. So OT is a continuing qualifying service, as it's currently referred to in the benefits. And in home health care, with home health care agency coverage, it sort of stands alone right now, where occupational therapy is not on equal footing with our physical therapy and speech language pathology colleagues. In every other setting, we are on equal footing under Medicare, but in home health agencies, we are not. And basically, what that means is, in order for occupational therapy to qualify for home health coverage, the beneficiary has to have occupational therapy established by virtue of a prior need for intermittent skilled nursing or speech language pathology services or physical therapy in a current or prior certification period. You can see the Code of Federal Regulation sections 409 here that I would point you to get further information. So continuing occupational therapy services that meet these requirements are at the section of 409 and considered to be those qualifying services. This means, so OT must have a prior referral that includes nursing, speech language pathology or physical therapy, then to be brought in as a continuing service. And then OT can continue in the home, and this is a real point I want to make clear. OT may be continued even after nursing, physical therapy, and speech language pathology are discharged because of OT status as a continuing qualifying service. AOTA gets many, many questions about this, and so it is important to know, as it currently stands, that OT can continue in the home even if nursing, PT, and SLP are discharged. You know, we want to point this out because patients are frequently going home from either hospitals or other post-acute care settings sooner and sicker than ever before. There are continuing workforce shortages that have further added to the challenge of delivery of services in the home. And we believe that OT interventions go beyond the basic activities of daily living skills training and can really achieve improved patient outcomes and reduce costs for home health agencies. Next slide, please. So, and in focusing on that, I think it's a nice juxtaposition to when we talked about what OT is, again, in that earlier slide, and Judith's discussion about home health aides. One of the things that we often try to help members and consumers distinguish occupational therapy therapists and therapy assistants from, for example, home health aides, when we think about things like activities of daily living, is that occupational therapy practitioners really work on that teaching and training component. So teaching and training, dressing, grooming, taking a bath, so that ultimately the client can do those skills on their own. And that is what makes those types of interventions, or what makes occupational therapy skilled. I know we got some questions about that from participants and want to keep making sure we hammer that home, that just like physical therapy and speech language pathology, these professionals are qualified and trained for many years in their educational program to provide these skilled interventions. So to move on, OTs can perform the initial and comprehensive assessments required to open Medicare home health cases. This is actually a slide we're really proud to present because just to step back in history a little bit, when the COVID-19 pandemic hit, there were a number of flexibilities put in place. And one of the flexibilities put in place, I believe in 2019, was that occupational therapists could perform initial and comprehensive assessments to open the Medicare therapy cases. That during the period of time, that law, there was a law passed in 2020, and then through the rulemaking process, we'll talk about in a moment, in January 1 of 2022, OT practitioners were allowed to complete an initial assessment and a comprehensive assessment when OT is ordered with another qualifying rehab therapy service, such as speech language pathology or physical therapy, as Judith mentioned. This gives agencies permanent flexibility to use OT at the start of care for any referral that includes occupational therapy and another therapy. So again, PT or SLP, to establish eligibility for occupational therapy. We do encourage you to make sure you check your state laws and regulations to verify that occupational therapists are allowed to do the start of care in your state. There may be some exceptions, but this is generally the rule nationally. And we're going to talk about in a moment how AOTA is currently advocating for OT to be viewed as a qualifying service, meaning that another therapy would not need to be on the order. Next slide, please. So again, looking ahead, we're advocating for legislative changes in the areas that I just mentioned. Next slide. So one of the ways in which we're doing that is through a piece of legislation called the Medicare Home Health Flexibility Act that AOTA's Federal Affairs Department has been working extremely hard on for the last few years. The Medicare Home Health Flexibility Act victory is the one I just mentioned, where legislation was passed in December of 2020, which instructed Centers for Medicare and Medicaid Services to allow occupational therapists to conduct an initial and comprehensive evaluation to open Medicare home health cases. That was following on the flexibility of the pandemic. That legislation made its way into the federal agency rulemaking process with a proposed rule and then a final rule coming out for being effective January 1, 2022. It was a huge victory for AOTA, and we believe our fellow colleagues in home health to be able to provide that flexibility to allow occupational therapists to open Medicare home health cases. Next slide. And so what that now means is that while OT can open cases when physical therapy and SLP are on the order, OT does not qualify currently for the home health benefit alone. So OT cannot be ordered as a solo service. Interestingly, just as a point of fact from history, in 1980, occupational therapy was a qualifying benefit in legislation, but was removed in 1981 for budgetary reasons, of details of which I will not go into, but there is some history here that's unfortunate and that we're trying to get back to that point in time. So the current Medicare home health reimbursement model, which is called the patient-driven groupings model, would reduce the cost to Medicare to change the policy and make OT a solo qualifying benefit. There could be cost savings involved in making that change. And so we strongly believe that the time to make that change is now. Next slide. And this just provides you with information about what our federal affairs team has done. There's a piece of legislation under 7148 that was introduced January 30th of 2024, with lead co-sponsors Smucker, Doggett, Joyce, and Tonko. We have worked really hard to receive the endorsements of a number of healthcare organizations, including NAHC, the National Association for Home Care and Hospice, the National Association for Rehab Providers and Associations, and Advion, the group that represents the skilled nursing facility industry. And there's a recognition that really home health is in crisis in rural and underserved areas, and that the additional availability of occupational therapy could help. There was a Senate Finance Committee hearing in the fall of 2023 to address some of these issues with Medicare home health policy. And we continue to meet with Ways and Means, Energy and Commerce representatives, as well as work to identify a Senate champion for this legislation going forward. Next slide. And just a quote that has been published from one of our champions, Lloyd Smucker, that this bill would make sure that seniors can receive the care that helps them manage their activities of daily living and thrive in their homes. So just, I would like to reiterate before moving on last slide to be very clear that basically OT currently is not a qualifying service. It means that if nursing is on the order, nursing must open the case. But if it's what we call a therapy only case, OT and PT or SLP must be on the order, then OT can open the case. We're trying to move to a certain scenario where OT can open the case without those restrictions. Next slide. And I thought I would be remiss to not just mention that sort of slightly off topic, but relevant to a slide that Judith gave earlier about caregiver availability. Starting January 1 of 2024, AOTA, APTA, and ASHA all together advocated for the development of 3 caregiver training CPT codes. I understand that home health agencies can't bill using CPT codes, but I believe these services are available to home health agencies or are something that could be advocated for by patients and those in need of home health care services. And these training services would allow for caregivers and family members to be trained in strategies and techniques to facilitate the patient's functional performance in their home or community. So some examples, as we've spoken about, are ADLs, instrumental activities of daily living, which again are things more complex ADLs like cooking a meal, money management, accessing transportation, things like transfers, mobility, feeding, eating, and swallowing, think functional cognition, issues with problem solving, sequencing, etc. So we wanted to make sure that you're aware of the availability of caregiver training services when those services are needed. And I believe with that, I am turning it over to Ciera Whitmore. Ciera is an occupational therapist and an AOTA member with Stillwater Health Agency, and she'll tell you more about herself. Thank you.
Yes, so my name is Ciera Whitmore. I have been an occupational therapist now for 10 years. I have worked all 10 years within the home health care setting, within the Part A beneficiaries through CMS. Basically anyone that's adult. So I have seen some more like 20, 30, 40-year-olds, but primarily most of my patient caseload is at 65 years and older. Besides that, I've had a little bit of experience in a hospital-based outpatient clinic. I will say, so I'm located in Stillwater, Oklahoma. We are considered a rural facility. We are about an hour out of Oklahoma City and an hour out of Tulsa, which are 2 major metro areas in the state. We're a hospital-based home health agency, so that does give us some little differences versus a more private-based home health agency. But I've really been working on especially since 2021 with the impacts of PDGM on payment to agencies and what the availability is to provide the services that CMS says are available under the home health episode while maintaining financial solvency so that we can keep our doors open and be able to provide any services at all. So a lot of this is coming from sort of that real world application and that sort of stuff, but trying to show where, I believe, like Sharmila said, where, especially in rural and underserved areas, home health care is really struggling at this point to meet the needs of the beneficiaries, and where you can do as advocates, as beneficiaries yourself, to know what are your rights and then what are the benefits and what we need to do to change some of this. So a lot of what CMS does look at, so the payment-driven groupings model, they look at how sick a patient is based off of our initial assessment. And these are some of the areas that they are looking at that can impact how much they are willing to pay us. They are also areas that occupational therapy can improve, which becomes more important as they roll out value-based purchasing that can further impact our payments that we get. So if you want an idea of just some of the stuff occupational therapy can address, this is a great list of it. And we will go into more detail, especially on the highlighted areas. I wanted to include some with bathing, just because that's most people recognize that as an area of occupational therapy, but even areas within management of oral medications and falls, which can sometimes be felt like those are addressed more by other disciplines, and how occupational therapy's specific lens is important and vital within the home health setting. Next slide, please. Yes. So occupational therapy in this new era. So how do we improve the access to patients but also maintain costs? I had known I wanted to be an occupational therapist since I was in 4th grade. Personal stuff that went on there, but I came to a realization in a hospital pediatric ICU room that I wanted to be the one to help people going through one of the worst times of their life to get back to where they want to be. I want them to enjoy life again. And so that is what brought me into it. What I now recognize is that I also need to be able to make sure that I do my part as an occupational therapist, as someone within the healthcare system, to ensure for me to be able to do that, that we also are aware of the financial aspect of this. And so we'll go into some of that as well, just so you have the full picture of what's going on here. Next slide, please. So this is taken from an actual patient I had earlier this year. This is what we get from our electronic health record system when we complete that original start of care assessment, start a patient on home health systems. Based off of scoring on our initial assessment, which is that OASIS that OTs are now able to complete. This one did have nursing, so nursing was required to complete this. This patient had, about a month prior to starting home health services, had a stroke in the right optic nerve that impacted her vision. That stroke was due to uncontrolled hypertension that was still uncontrolled at the time of start of care. That had also led to multiple falls, as well as the fact that she now had decreased depth perception due to the vision issues. One of those falls resulted in a dislocation of her left shoulder with decreased range of motion. So you can see in the highlighted yellow areas, that is what, based off the information we provided our electronic health record system and the information we have from CMS, that is what is our expected payments. Right now, we are a smaller home health agency. We don't have a good way to determine the exact cost per service for a visit. So what we utilize currently, we're in the process of trying to determine exactly how to figure out that money aspect of it. We're using our billing rate. So if this was a commercial private insurance, this is what we would bill them per visit. So we're using that to determine whether we are in the positive or negative at the start of this. Obviously, this patient has multiple things going on. And so, but we still only get $2,100 for the first 30 days and $1,500 for the second 30 days. based off of the number of visits that each clinician determined was appropriate after the initial evaluations. We were already at negative 2,000 in the hole. This was further complicated after the first 30 days. Her left shoulder developed adhesive capsulitis, so it was frozen, which clinically requires at least 2 times a week for OT to come in. I was the one addressing her shoulder to try and decrease the pain and increase the functional range of motion. So she could do bathing, dressing, play with her dogs, all the things that were important for her. But this is where it comes in. We can say that, well, Medicare requires, like, you can have daily school nursing, you can have all this. And ideally, yes, I would love for our patients to have that. But if we give all of our patients everything that they could, and this is where we look at, for this patient, we could justify, like, this person had it. There was no way we could not provide these services for her. So we did take the cut. But it makes it very difficult for smaller agencies, especially if they're standalone private agencies, to manage if they're consistently having to go spend more on the services than what they're getting paid by Medicare. Luckily, within the hospital system, we've got other areas of the hospital that can offload. So if we're in the negative for a year, but ortho in the hospital did really great, then that offsets some of our costs. So that's one of those areas that we just have a little bit more leeway being in a hospital system. Next slide, please. So with this payment change, there have been increasing ethical concerns from occupational therapy practitioners of what agencies are saying Medicare is limiting. And these are not Medicare limitations. Judy Stein went very well into exactly what those Medicare limitations are. These are agency limitations to try and either make a profit or at least to remain financially solvent. So some of those that you might hear from beneficiaries is that they limited visits per discipline. So maybe that patient that I showed you with, they initially said, you know what, there's 2 nursing, there's 3 PT, and we'll give 5 OT, and that's it. We're not doing any more. That's all they can have in this maybe 60 days. Maybe if you go into the next 60 days, which is a new certification period, then we can maybe look at doing a few more. A lot more agencies are doing limiting visits per patient. 7 tends to be the most common number, and there's a reason for that. There's a low utilization payment adjustment. So basically, if an agency doesn't do at least 4 skilled visits within the first 30 days, then Medicare says, hey, you've got to pay us some of that money back. And a lot of times that is 4 visits in the first 30 days and about 2 to 3 visits in the second 30 days. So this is one that's starting to crop up a lot more, that therapists are saying, nope, my agency's saying, we evaluate nursing, PT, OT, whoever's in, you guys have to discuss and decide how you're going to break up those 7 visits. Again, for that patient, that was not going to be appropriate. For my stroke, for a lot of our patients, that's not. There are some patients that, yes, we can probably manage within 7. Our CHF that maybe just needs some education on energy conservation and maybe just periodic check-ins to progress. It's really based off that skilled assessment. There's been some increase in productivity expectations. Another one that's being talked about is OT evaluations being asked to defer until PT has completed, so they don't want more than 1 therapy at a time. And then there have been also increasing reports of, I put PT, but it can be other disciplines. Basically, the physician orders home health and says this patient needs nursing, PT, OT. The agency is telling nursing or PT to go out and assess to see if they really need occupational therapy. And if the PT or the nurse decides, oh, they don't really need OT, they're faxing the physician, say, based off PT, they don't think they need OT, and the OT never even goes out to assess. We also have agencies telling occupational therapists not to address IADL. So these are the instrumental activities of daily living. This would be things like home management, laundry, meal prep, medication management, getting back to their desired hobbies, activities, roles, responsibilities. That all that can be addressed once the agency discharges in outpatient therapy. So those are those are the main ones. going through some of my Facebook groups, through AOTA boards that we've been talking about. Those have been the main ones that I've been noticing over the past 3 to 4 years. Next slide, please. So this is where me and along with Sharmila, where we've really been trying to work with addressing these concerns. So one is educating stakeholders, such as a lot of you on this call, on what the role and benefit of OT even is within the home health setting. If we have 100 OT voices, legislation, Congress, all that's not going to listen. If we can add to that all the advocates, all the beneficiaries, knowledge of what these services are and why they need them, we have a lot more sway. We're also trying to educate clinicians on what are the Medicare regulations, such as Jill Stein stated, versus what agency policies are saying that they are limited by. And then also trying to encourage to demonstrate the benefit of OT, especially with agencies that might be more focused on the financial aspect, how OT does improve that quality and therefore can improve reimbursement, that money aspect of it, to make sure that everyone is aware just how vital occupational therapy is within the home health setting. Next slide, please. So to start off with some of the more specific what occupational therapy looks like within the home setting, I want to go over one of the frames of reference. So this is basically what occupational therapy is looking at during that initial evaluation. There's several different frames of reference. This one is called the person, environment, occupation model. I use it because it is one that I use with probably 90% of my patients, because than in the patient's home, and this is the only setting where occupational therapy can see patients in the home. Where those three areas converge is their participation or their occupational performance. This might also be stated as the patient's stated goal. My goal is to make it to my granddaughter's graduation. My goal is to be able to get out and drive and go to the grocery store again. So therefore, in my evaluation, I'm looking at the person. What are their diagnoses? What are their limitations? Is it strength? Is it poor sensory awareness? Is it environment? Are there floors cluttered? Is it financially limiting? So that can be part of the environment. Maybe they don't have the social support to really be able to participate in what their desired goal is. And then also looking at what specific occupation. Is it, I want to be able to bathe myself? Okay, then how does what the person's deficits in the environment impacting on the occupation? And those occupations, again, are just anything you do throughout the day. They're habits, roles, routines. They are all the things that you do that make you you. So it's looking at that lens. And so I put this, especially when comparing occupational therapy with physical therapy. If I'm focusing on the person aspects that might be limiting, it might look a lot like physical therapy. It might be some strengthening or some balance exercises or something like that. But I'm looking at it to try and get them to this certain area. Going back to the patient's stated goal of making it to a granddaughter's graduation. So the physical therapist might be thinking of like, okay, they need to be able to walk, get up and down, all that. I'm looking at what will their environment be? Okay, graduation's often in a stadium. Will they be able to sit on an end row? Will they have to manage those steps to get in and out of the stadium? Is it a 10-hour car ride? Okay, they can transfer in and out on their toilet here at home that has all the adaptive equipment, but what about one at a gas station, at a hotel, any of those sort of things? So you're really looking at it from that whole aspect. Another patient we recently saw was having balance issues. She wanted to get back to doing laundry. PT had already evaluated, yeah, we need to work on balance within our home, all this sort of stuff. I go into laundry and I'm like, okay, well, here's your washer, where's your dryer at? Oh, the dryer's out in the barn. And again, this is rural Oklahoma. Well, the barn is down 5 concrete steps to grass, down a hill, and literally in the barn, about 40 feet away. So I go back to PT and I'm like, okay, so yes, you need those goals. You also need to make sure she can get down there, because I really need you to work on this advanced balance so we can meet that goal. And so that's where I might also work with PT. We talked about OT deferring till after PT finish. Sometimes through my clinical judgment, I will defer, like with that patient. I'm like, you know what, PT is the better one to address this balance. I will follow up with you in 2 weeks once she says your balance has improved, and we will make sure that you're safe managing the laundry basket down there, managing all that sort of stuff, more from my point of view. So that's where we can sort of work together as well. Next slide, please. So key areas, again, ADLs, bathing, dressing, toileting. Again, you might see that that looks a lot like the home health aide. Again, the aide is often a support person to maybe provide respite for the main caregiver, to provide assistance to somebody who doesn't have available assistance in the home for bathing. My goal for the most part is to try and get them more independent. Now with the maintenance patient, it might be to allow the aide to be in there for respite, or it might be to work with the family to determine, are there ways that can make this easier so it doesn't wear out the caregiver as much or wear out the patient as much, such as with ALS or Parkinson's or any of those sort of diagnoses. What I've found is that I'm actually very much involved in training all of our aides. I will communicate with our aides after I evaluate each time, say, hey, I really need you to help this patient to utilize the hip kit because they don't have family to help when the aide's not there, and to really try and progress it. And it's very much a very cohesive relationship that I have with the aides when we have them. Again, another issue is, we're an agency. We have not been able to find an aide or have an aide for 2 or 3 months now. There's just none. And the legal thing for us to do is, when we get an order with an aide, is we call the patient and say, we don't have aide services. Do you want an agency with an aide? If they say yes, then we refer them to one of our local agencies that does have aide services. But we do also have medication management. I want to go into that because that tends to be something most people feel is more nursing, and then falls because, again, balance tends to be something that is perceived as more physical therapy, and just to better showcase how OT's frame of reference can really facilitate that. So, next slide, please. So occupational therapy's role in medication management, it is considered an instrumental activity of daily living. Medications are critical to treating and managing health conditions, and we are very well trained to do this. Next slide. So different ways we can do this through occupational, incorporating into daily routines, requesting refills, how to change the environment. Maybe it is working on hand strength and some of that as well. And so these are just some of the different ways. Next slide, please. So one of the areas I like to educate is the difference between nursing and OT. A lot of times on this part is medication education versus medication management. Education is a lot of definitely nursing area. Dosage, purposes, side effects, refills. Do those medications go together? A lot of medication management is more, are they able to take their medications at the correct time? All that sort of stuff. So it might be looking at their environment. Are they cognitively able to manage their medications? Can they see their medications? And their physical. And so I do put on here, this is actually one of my modifications to a patient who had low vision. You can see in that first one, when it's white, the white pills are very hard to see. And so she was missing a lot. I could look at her med planner and see that, yes, she took her meds, but she also missed quite a few meds. With cognition, I've also had people get confused when there's multiple slots, and if they don't have one, I will just tape it over so they can't even access it. There's also certain med planners that are easier for those with arthritis so that they can manage that as well. So different ways that we can look at that medication management. Next slide, please. other one is just task modification. So the medication list on the left is what is printed out if we just go through our electronic health record system. The print is small, it's not in any particular order. It's not really beneficial to patients, especially if there's any sort of cognitive deficits and they're trying to fill their med planner on their own. On the right is an example of some of the modifications I'll do. I'll take that exact same medication list and I divide it into AM and PM medications, and then they're as needed, and makes it a lot more. I'll use larger print, so that font, so that they can see it. It's in a lot more cohesive, so if they're filling it, they know that they fill their AM portion first, and they can do both their AM and PM, and then move down the medication planner to appropriately fill their medications. Next slide, please. I did throw this quick case study in because it was one of the first times that nursing finally had recognized what my benefit was. We had an 80-year-old woman referred to home health for nursing PT and OT due to falls, but she was also legally blind due to macular degeneration. She was adamant she was going to keep managing her own medication and did not want the use of a meal planner, but had extreme difficulty reading the labels. Nursing went in and educated on the med planner, patient declined. Nursing educates on blister packs filled by pharmacy, patient declined because her pharmacy didn't do it. She did not want to change pharmacies. Nursing then requested OT. So again, we've looked at, the nursing was looking primarily at the occupation in the person, knowing that she couldn't see, was trying to modify the occupation. I come in and realize that really I needed to include the environment aspect of it if I was going to meet her occupational performance and meet that goal of being able to do it on her own. So I went through and saw that she could still see, for her personal aspect, colors, contrast, and large bold print. She did have a magnifier glass, but did not like to use it. She also had come up with a modification already of trying to write on the tops of the labels in large print what each medication was, but could have trouble because there was also printed stuff. So I came up with this color scheme to utilize it. She was able to correctly take her medications, learn how to use it while she still had some vision left, and hopefully could continue to use it for a while, since color will tend to remain longer than being able to actually see the print. Next slide, please. The other area is falls. So the Office of the Inspector General has noted that 55% of falls identified in Medicare claims were not reported appropriately on the OASIS assessment. So the OASIS is the initial assessment that we provide to CMS as a home health agency on the patient's deficits. We also provide it at the end of services. So there is a lot of focus now on correct reporting of falls within the home. And especially falls that result in injury within a home health episode. Next slide, please. So with that, there's been a lot of focus within my agency. I was actually part of a performance improvement project, and we decided to utilize the STEADY protocol provided by the Centers for Disease Control. And within that protocol that the CDC has provided, they even specifically stated OT as a valid part of the multidisciplinary approach to reduce falls. It gives, and in the home health setting especially, it gives us the opportunity to evaluate the person and the environment and start the appropriate services or modifications they need. We individualize evaluations that lead to identifying a person's unique fall risk with the STEADY program. So whether it's their medications resulting in falls, maybe it's their balance, maybe it's their environment. And really the focus here is to ultimately benefit the patients. Less falls means decrease the risk of ED, further complications. And then if I'm going to the agencies who are wanting to save money, it also improves on the value-based purchasing, as well as just the payment models and star ratings as well. Next slide, please. So OT with falls, these are just some good examples of what we can. I'm going to start in the upper right-hand corner, the white bathroom. This is common. Anybody with some low vision is going to have more trouble here. adding some color contrast. It might be something as simple as putting duct tape on the edge of the tub so that they stop stubbing their toe on the edge of the tub. You'll also hear a lot of people when they start talking home safety to get rid of rugs. I will tell you that that's not necessarily the best thing to reduce fall risk. I would rather have a rug outside the tub than having them slip on a wet floor. Now I will check and make sure it's a non-slip back on the rug to help with that. The lower right-hand corner, this is a lot of my patients' houses where it's just cluttered, and we will say they have an adequate walkway space. Basically, they've got it cleared enough that they can get their walker through. I'm not going to change this within the home health setting because that's just how the person is. I can't change that without the patient being willing to recognize that that is an issue and to change. So what can I do is make certain recommendations. Can I at least move this table out of here for right now while you're still using the walker? Once you're no longer on the walker, you can move it back. Okay, well, if it's just a temporary, then they might agree to that. Can we add some more lighting? You know, it's awful dark, and if something does fall off of here, will you be able to really see it? Just making those small environmental change when I can't necessarily impact the whole environment. Recognizing most of our patients have some normal vision, whether it's cataracts, macular degeneration, glaucoma, any of those sort of things. And again, if you're looking at that example of cataracts and then thinking of the cluttered room or the white bathroom, how that's going to make that so much harder and increase risk. The one on the far left with falls, I like to bring up a patient that we had that we do report every single one of our falls in our agency. And that allowed my director to recognize that when 3 different clinicians reported a patient fell and that each time the patient was reaching up in her cupboards and lost her balance backwards, maybe we need to move her cups further down so that she's not reaching up and losing her balance. And the top center one is just the common, again, the rugs, the coffee table. And so looking at, again, I'm in the patient's home. I can't just change their whole life without taking into account what they want. They might decide, you know what, I don't like getting up that much, so I have everything I need right next to me. Okay, that's good. That does limit how much you get up, but let's make sure, are you aware to pick up everything before you stand up so it's not a trip hazard? Next slide, please. And I think at this point, I actually hand this back over to Kathy.
Thank you, Ciera. Oh, that was just amazing. You know, I have to stop for a second because so much of what you talked about is stuff that we hear about at the Center for Medicare Advocacy, that people can't get all of the services that they need. And as Judy mentioned, if you have an order for services, those services should be delivered. And if the ordering practitioner determines that you need those services for your safety in particular, but also for the effectiveness of the service, really important, both of those things, safety and effectiveness. We have to all work together to figure out how to make all of the services that are necessary for the patient be delivered so that the practitioners like yourself are not put into a difficult ethical position, but also that the providers get the reimbursement that they need in order to make sure that all the patients get those services. So we will continue to participate with one another and to collaborate in ways that we have and continue to do going forward to make sure that we are delivering those messages to the people that need to hear them in order for the services that Congress has ordered be delivered for patients to actually happen. So we're short on time. I had prepared some remarks that I'll go through briefly, but please know, everybody, thank you for hanging in there with us. This is really a fabulous opportunity for us to hear from the practitioners who actually are on the ground doing this work. And what I want to do is to be able to have us have an opportunity, a little bit of time to answer some questions that were brought before us. We've tried to incorporate as much of that as possible. But let me move some things around on my screen so that I can move this forward. One of the things that I want to say about this case study in particular is that everything in the policy manuals, and Judy in particular mentioned the policy manuals, but we all have the value of them. There's a lot of detail in the policy manuals, but more importantly, there are a lot of examples. And we took this example directly from the policy manual, and essentially it's about a person who's had a stroke. It doesn't really matter what the condition is. And one of the questions that we had from someone was, does the health condition have to be related to work? No, has nothing to do with work, the work that you used to do. As Ciera and Sharmila had mentioned, this is your occupation, is how you live in your home. But the important thing to look at from this case study is the fact that any individual, for whatever reason, be it a stroke, be it an injury or an illness, they have, in this particular case, they have decreased range of motion, strength, and sensation in their upper and lower extremities. So any of these types of symptoms are going to lead to the need, potentially, for occupational therapy. So essentially what the case study goes on to say is what would someone be able to benefit from an occupational therapist? Well, an assessment, goal development, manufacture of whatever equipment will make the person's condition be more tolerable for the issues that they're dealing with. Are there compensatory techniques to strengthen the patient as necessary, or to maintain as much of that function as possible, and to provide whatever activities are directed toward meeting those goals to improve or to maintain the function as necessary. I want to turn for a second to our work in home health aid services. And Judy spent quite a bit of time talking about the home health aides and what a critical part of helping people to stay within their homes. Essentially, what we have learned over time in our work in this area is that home health aid visits have declined by 90% in the last 25 years. And there's been no change in Medicare covered services. So you heard Ciera talk about the shifting of the incentives, whether that be in quality measurements or it be in payments from the Centers for Medicare and Medicaid Services. These are some of the influences that we see happening with home health aides. Again, the law says you should be able to get on average up to 4 or 5 hours of aid services a day. Critical to have someone come in the morning to help you get ready for the day, and then come in the afternoon to help you kind of reverse the process. But we know in practice that beneficiaries are told that these aid services are limited, and you heard from Ciera that they haven't been able to hire an aide for several months. So not every agency is going to be staffed in the same way. That's why it's critical to be a little creative in terms of calling a number of agencies to see what staff they have available. In response to all of our work that we have been trying to do to get coverage for home health aides and to understand why this precipitous drop in the hours and the visits for home health aides has happened, we ended up having to file a class action, or a proposed class action lawsuit. We filed a lawsuit, and it'll be almost 2 years this fall, in order to get aides for individuals who really need them, in particular in order to stay in their homes, and for people who have longer term and chronic conditions that need aides, and it's a critical service for them. And what the case essentially requests is that the barriers that Medicare has put in place be removed so that people can get the aid services that they need, that the correct incentives be made to the home health agencies in order for the services to be submitted. Part of the issue has been in the technical work of doing litigation and lawsuits is that you have to have certain technical requirements. Long and the short of it is, and again, won't go into a lot of detail, but currently the case has been argued before the DC Circuit Court of Appeals, and we are awaiting further information on that. But what's next for home health aides? As a result of the lawsuit, we have been told, although really doesn't matter, what is important is that CMS has issued a request for information addressing this crisis in access to home health aides. That was in last year's proposed rule, and the final rule for 2024 indicated where CMS said that they would take into advisement all of the comments that were received. We are currently awaiting any day now the proposed rule for home health care for 2025, and hopefully we can move the issue of access to home health aides forward, and we request that everybody, all beneficiaries, advocates, everybody respond to the proposed rule in a way that shows our concern and the need for home health aides. There are, as I mentioned, and as has been mentioned throughout the program, additional obstacles to obtaining access to home health care. Medicare policies really focus on people who are post-hospitalization and for people who can improve and get better. To say that's not fair is an understatement, because people with longer term and chronic conditions that qualify for the services under the program should have access to those services. And again, part of what our lawsuit talked about was the discriminatory nature. And we've seen a lot of changes with regard to health equity and discrimination. And we are making sure that our voices continue to be heard about the ways that we can get access for patients to these services. We know that private Medicare Advantage plans often provide even less services or authorize even less services for individuals through home health agencies than traditional Medicare. So the adequacy of the private Medicare Advantage plans is something that we have a lot of concerns about and that we're putting a lot of attention toward. And again, any kind of these deterrents, such as audits or quality measures, programs that incentivize short-term post-acute care, are things that we are looking to combat against. And we do this through the help of individuals like you out there who can tell us your stories. So there are ways to kind of strengthen your own knowledge about how do you access services. Certainly Judy did a great job, and all of the information that she has is cited very specifically so that you can use that information when you are trying to convince or reassure a home health agency that yes, indeed, this is Medicare coverable, the services that you need. The Medicare conditions of participation are very friendly to patients, meaning that they require patient involvement in care planning. We often hear from patients who say, my home health agency says that they don't have to provide me with my plan of care. Yeah, they do, and they should involve you in creating that plan of care as well. If a patient is going to be discharged and they still need services, it's incumbent upon the discharging agency to arrange for a safe transfer of patients. We often see patients that are just told that they're being discharged, and those arrangements are not made. So how do you enforce these conditions of participation? Every state has a licensing agency that such as the Department of Public Health, that licenses home health agencies. A call to them to say, I'm being unsafely discharged from home health care is important, but it's also really important to continue an appeal process. And the reasons why are that oftentimes when you appeal, and particularly when you get a written decision that you are entitled to those services, you can use that written decision to, again, reassure potentially another agency that you have been found to qualify for services. And then there are a number of other resources here that, that we use, again, to make sure that people know what agencies you should look at. The compare tool on Medicare.gov will at the very least tell you all of the Medicare certified home health agencies that serve the zip code that you live in. By calling those agencies, you can at least get a sense of what the staffing is like and what services you might qualify for. There are other resources that we can use to point to that the coverage rules that Judy mentioned, and in addition, we often hear from people who say, well, what kind of documentation do I need? What does the order have to say? Mostly it has to do with that documentation in your own medical record that confirms the fact that you do have difficulty leaving home, that leaving home is a taxing effort for you, that you need skilled services to either improve or to maintain or to prevent decline of your condition. If your services needs change, your goals change, you may have had improvement goals and now you have maintenance goals. Make sure that the order is changed. The denial part of this is frankly the easy part, to make sure that you have the documentation. The more difficult part is the obstacles that the agencies are facing in trying to provide those services to you that you qualify for. And again, as a last resort, we often say to people, look, you know, if an agency can only provide you with 7 occupational therapy visits, you know, is that better than nothing? It's not the answer. It's not the answer. We're not settling for this, but it's really important that we get a foot in the door, you get those services, and then if the services are stopping and they shouldn't be, to appeal that and make sure that you can continue to get the services. Other things that we're doing obviously is working with the providers, working with these wonderful associations like AOTA, asking people to work with us, send us your stories at homehealth@medicare.org, medicareadvocacy.org, so that we can help to do that. And we know that people need these services. There's a reason why Congress created the benefit in the way that it did. It's the law. Congress got it right. This is one of the things that we kept arguing when we were arguing the home health aid case in the DC Circuit Court of Appeals. Our wonderful litigation director, Allie Bears, kept saying, Congress got this right. If we could get the services and the criteria and the coverage that Congress created, then we could have a much richer, better benefit that will serve people much better. It is the law. And people who qualify for these services shouldn't have to pay by themselves. They shouldn't have to go without, and they shouldn't have to shift the cost to Medicaid. We know that it's important to all of us, and we hope that we can come together in all of the ways that we have been trying to move the needle on this. The next few slides are just more information. We have a lot of research and writing that we've done on our website under home health. And there's a number of studies and further documentation. Would point you, if you're looking for assistance with finding home health agencies or looking for information generally about Medicare, to contact the state health insurance programs. They are our only trusted community resource. And so there's information here about how you contact the state health insurance assistance programs. And here AOTA has provided additional resources as well. So thanks everybody. I will see that we're just 2 minutes up on the end of our program, but if everybody can stay on, if people want to stay on, we'll be happy to have a little bit of a conversation.
All right, we do have some questions. I'll lump a few of them together into the sort of forever question, and I know Judy will be excited to answer this one. And basically, it boils down to, is there any difference in coverage in original Medicare and Medicare Advantage, other than maybe you have more trouble with one than the other?
Well, I will answer that first as a lawyer. Under the law, Medicare Advantage plans are required to provide at least as much coverage as that which is provided under the traditional, sometimes known as the original Medicare program. So everything that I expressed with regard to Medicare coverage for home health care is true legally for both traditional/original Medicare as well as for people who are enrolled in Medicare Advantage plans. That is true. In fact, Medicare Advantage plans might offer more theoretically, but we do find that sometimes the Medicare Advantage plans are more stringent in their requirements. For example, they may well require some sort of prior authorization before allowing admission into Medicare coverable home health care. They usually will have what's called a network, and that means that an individual enrolled in a Medicare Advantage plan would have to get the home health care from a Medicare certified agency that is in relationship with the person's Medicare Advantage plan. So the enrollee might have fewer options with regard to home health agencies. And of course, all the care we discussed must be provided by a Medicare certified home health agency. So some Medicare Advantage plans do have a co-insurance for home health care. And while I didn't mention this, under traditional Medicare, there is not only no duration of time limit, which should be true for Medicare Advantage as well, but there also is no co-insurance. That is, patients in traditional Medicare don't have to help pay for their home health care. Some Medicare Advantage plans do have a copay. So there are differences in practice, but under the law, everything we told you about coverage rules and criteria are the same for Medicare Advantage as for traditional Medicare. I hope that answers the question.
I think so. We had some thematically grouped questions for Sharmila and or Ciera too. People are asking about who can cancel or override orders for OT, PT, etc. And again, I'm trying to glom some questions together. Carol, for example, works with physicians who order OT along with nursing or PT and then find that somehow the agency canceled the order. The patient never got evaluated. Lynn says, can the actual therapist decide that it's not merited anymore? So if that's clear enough to be a question.
For the most part, Medicare plan of care, as I believe Kathy said, is supposed to be patient driven. So the only time I will cancel an OT eval is normally I call the patient and they're like, I don't think I need OT. And I'll go through, well, this is what I'm looking at, all that sort of stuff. No, I think I'm good. And I might say like, okay, I might go to one of the other clinicians, like, are they actually good? Or do I need to really try to convince the patient a little bit more? And they'll be like, no, I think it is, or maybe give us a couple of weeks and see. That's the only time, is because the patient said they did not want the OT evaluation. It's not because I just didn't have room on my schedule and I decided that I just didn't see that patient. That's not appropriate. Same thing with other disciplines, determining that it's not because they don't have the knowledge, background, the degree. That goes with the fact that I can make that decision and they can't.
Yeah, I absolutely agree with Ciera, and AOTA's position is that that would not be appropriate unless it was a patient denying the services themselves. It definitely, if it is on the referral, we believe that the occupational therapy order should be honored. And I think that really gets to what Ciera said about the difference between what are CMS laws and regulations and what are agency policies that may or may not be able to be enforced and probably should be challenged in many cases.
Thank you both very much. Again, we're looking for clumps here. We have several people with hands up too. I don't know how brave we want to be. Do we want to try to take a live question here and there while I'm scanning?
Okay.
I see nodding.
Sure.
All right. Then let's go to Bienvenida. Are you there? I'm unmuting you.
Hi, I had asked a question about when you want this home safety assessment like for a bathroom to have grab bars. Is that OT or would that be PT? How do we get that approved through Medicare?
So a basic home safety, if it's only just for that, a lot of times tends to be more through an outpatient OT, mobile home health Part B. If all you're needing is an assessment within the home for safety, it tends to be more that. I've worked a couple of times through specific grant funded programs that have had, they've reached out to our agency and said, hey, we've got a patient. This is an area we don't normally have anybody. They're leaving our program. Maybe it's a post TBI, something like that. Can you go in and we'll just pay you this lump sum? It's not normally through a Medicare benefit, again, because Medicare requires that it's that OT is not a qualifying service. I would need to have PT in as well. Now with the new Home Health Accessibility Act, if that gets passed, that could possibly be a reason if they are homebound and meet all the other criteria that I could come in. Because it's not, PT normally doesn't do much with home modifications in general. I say in general because there are sometimes a few PTs that have gone a little bit more that route. It tends to be more through an outpatient Part B benefit versus a home health, just because of that OT not being a qualified service.
Thank you very much. We have these sort of business side specific questions. There are people who are concerned about how agencies can increase their number of visits, but still stay lucrative financially. I think going back to Ciera's very graphic chart with the dollar amounts. And then also there are agencies wondering about, people wondering about folks who just can't afford to pay for private home health, but the agencies might offer care through private pay that they don't offer through Medicare or Medicaid. Any insight on the business side of things for folks?
I mean, the first part is one of the hard areas because that's where I recognize that I have to modify some of what I might have done 10 years ago when I first started for frequencies versus now is where I recognize where am I most beneficial and where I will step back a little bit at first, let PT do their work, but I also will stand up and say, we had a patient who needed help with multiple ADLs. His wife normally did it. His wife was scheduled for a hip replacement in 2 weeks. They had no plan on who was going to help him. He couldn't do it. I told PT, I'm like, I need you to back off. He's lived with not being able to walk very well for a year with only one fall. Let me address his ADLs or else we're going to end up with both him and the wife in the hospital. So it's where you do have to have some of those conversations, but you still try and keep. It also comes down to there's no evidence base for me not to see a patient 2 times a week who's had a stroke. There is nothing that says less therapy earlier on is going to be better for that patient with the stroke. And I will fight anybody who tries to say differently. With some of the other more chronic, yes, they've lived with it. So is it not maybe better to spread it out over 3, 4, 5 months and make sure that it's actually ingrained in their habits, roles, and routines versus trying to do all my visits within the first 30 days? And so spreading it out is really one of the best ways to get those number of visits while maybe remaining a little bit more financially solvent. I'm not quite sure I understand your second question that was part of that, though.
Nor am I. It was basically as I read. I think it's basically, what if a person just can't afford to pay for therapy and can't get it covered by Medicare? That might be a Judy, Kathy advocacy question. I'm not sure there is a good answer to that question.
True. It just requires pushing back and giving it one's all with regard to all the citations we provided and stating that what the patient needs in conjunction with the OT and hopefully with the physician, getting that support along with the citations provided in the statements about that this is covered by Medicare. And it's not a quick fix by any means, but if these services don't get provided, the person loses out. If they don't get billed, then they begin to build into the system what is expected with regard to services and what payments are. That is, it becomes part of the reality of payment models and of quantity of care that people can receive. So whenever it's possible to advocate for the actual services needed that are up to and including that which Medicare is required to pay for cover under the law, then we have to urge our colleagues in the field, OTs, to try and do that so that we then can advocate both for the individual patient and also, as we talked together, for OT in general, make clear that it's part of absolutely necessary care for folks.
I would echo that, and also we get questions sometimes about cash pay and the ability to opt out of Medicare, and it raises a very complex series of issues. Occupational therapists, physical therapists, and speech pathologists cannot currently opt out of the Medicare program. So unless a service is very clearly non-covered, they do need to accept Medicare payment. And so those issues sometimes get complex. So just want to point that out.
Thank you. That's perfect answers. And I think that's a good spot here to stop and to ask if our panelists have any closing remarks for us.
Well, on behalf of the center, just let me thank AOTA and the wonderful work that occupational therapists do. I'll tell you personally, on behalf of my mother and family, I know the magic that can seem to be magic to those in the family when an OT is skilled and provides care to someone who's recently become debilitated. It's a wonderful collaboration. It's a wonderful field. We're glad you're in it. And I thank you so much for joining us in this program.
Great, thank you. And we are very, very pleased to be partnering with the Center for Medicare Advocacy. In a former life, I was a health advocacy fellow for the Medicare Rights Center in New York. And so I'm a huge fan of the work. And I know AOTA is so happy to be able to work together.
It's a great marriage, shall we say. You provide the care, we'll provide the advocacy. You provide some advocacy, we'll try and get the care covered. Thank you. And thank you to everyone for staying on the web. Thank you, Matt.
I will echo those thanks. Thank you all for hanging out with us a little over time today. Thank you again to our fantastic presenters and to the American Occupational Therapy Association for making this presentation possible. Stay tuned on our website and our alerts for information on upcoming presentations, possibly with AOTA. Thank you all again. I will conclude today's webinar.
Thank you.